Okay, let's talk about anxiety and somatoform disorders. So, this chapter discusses the most important disorders associated with the presenting complaints in chapter 12, 13, 14, and 15, which you might find helpful to read first. Okay, let's start with anxiety disorders. About epidemiology, the anxiety disorders are the most common of all psychiatric disorders, with a combined 1 year prevalence rate of 12 to 17%. Epidemiological data collected from different countries have shown varying prevalence rates for the individual anxiety disorders, likely reflecting varying thresholds for diagnosis. Here we have a table that's about epidemiology of the anxiety disorders. So when we talk about generalized anxiety disorder, so the 1 year prevalence is 3%. The usual age of onset is variable from childhood to late adulthood. The sex ratio, female to male ratio, is to 3 to 1. Panic disorder with or without agoraphobia is 4%. It started in late adolescence to mid 30s, and the sex ratio is the same to 3% to 1, more likely to happen in females. Social phobia is about also 4%. It starts in mid-teens, and the sex ratio is about equal. Specific phobia is also 4%. It starts in childhood and or to adolescence. The sex ratio is 2 to 1. PTSD, the same thing, 4%, but it can start any age after trauma. The sex ratio is the same as specific phobia. We are talking about 2 to 1. OCD is about 2%. It starts in adolescence or to early adulthood, and the sex ratio is equal. So most likely we are talking about 4%, 4%, 4%, except for generalized anxiety, it's 3% 1 year prevalence, and OCD it is 2% 1 year prevalence. The sex ratio is almost always more prevalent in females, other than social phobia and OCD. The sex ratio is equal. Okay. It is important to remember that anxiety disorders are usually underdiagnosed in primary care settings, or only recognized years after onset. A large UK survey found that only a third of people with clinically significant anxiety disorders were receiving treatment of any kind, psychological or pharmacological. Communication. The anxiety disorders are frequent and closely related in etiology, symptoms, and management. For this reason, they are often grouped together along with depression under the heading common mental disorders. Common mental disorders. Okay, so hints and tips. In clinical settings, over 95% of patients who present with agoraphobia also have a current diagnosis or a past history of panic disorder. You may want to bear this in mind while screening for symptoms. Hints and tips, another hint. Anxiety disorders tend to be more common in women than in men, apart from social phobia and obsessive compulsive disorder, where the prevalence is about equal. Etiology. Let's start with genetic and biological factors. Genetic factors contribute moderately to risk for development for most anxiety disorders, with a heritability of 30 to 50%. Okay. There is likely to be considerable genetic overlap between depression. It is possible that different environmental experiences in most people with similar genetic vulnerabilities lead to either depression or anxiety or both. Panic disorder and obsessive compulsive disorders OCD appear to be the most heritable anxiety disorders, with more than a third of those affected having a first-degree relative with the same diagnosis. OCD shares genetic risk with Tourette's syndrome. Okay, so panic and OCD mostly heritable. Okay. The three main neurotransmitter systems implicated in anxiety disorders are GABA, serotonin, and norepinephrine. Evidence for their role is that these are the neurotransmitters predominantly affected by benzodiazepines, selective serotonin reuptake inhibitors, and tricyclic antidepressants. GABA, serotonin, and norepinephrine, or noradrenaline. Calcium-dependent neural signaling has been linked to anxiety by genome-wide association. Obsessive-compulsive symptoms are often reported following damage to the caudate nucleus in the basal ganglia, like Sydenham-Chorea. Amygdala hyperactivation is found in a number of anxiety disorders, including post-traumatic stress disorder and social phobia, in response to the relevant anxiety including inducing stimuli. However, anxiety disorders likely reflect abnormalities in networks of brain regions rather than individual regions alone. Okay. Social and psychological factors. Anxiety disorders have been linked to stressful life events. In PTSD, a significant traumatic event is essential to the diagnosis, although only around 10 to 30% of people who experience such an event go on to develop PTSD. Psychosocial stressors may also precede the most of symptoms in other anxiety disorders. Okay. Cognitive behavioral theories suggest that symptoms are a consequence of inappropriate thought processes and overestimation of danger, as in the case of panic attacks. A cognitive model of panic attack suggests that an attack may be initiated when a susceptible individual misinterprets a normal body stimulus. For example, patient may become aware of their heart beating. Instead of dismissing this as normal, they may assume that it is under excessive pressure and that something could be physically wrong. This fear activates the sympathetic nervous system, the fight or flight response, producing a real increase in the rate and strength of the heartbeat. A vicious cycle ensues in which the perception of increasing cardiac effort convince the sufferer that they are on the point of collapse or a myocardial infarction. The resulting crescendo of symptoms may proceed to a full-blown panic attack involving several of the panic symptoms listed previously in chapter 12. Cognitive behavioral models for phobias suggest a two-step process. A natural stimulus is paired with an aversive stimulus. This is by classical conditioning like driving and an accident, or anxiety is felt about an intrinsically aversive stimulus like snake. The natural stimulus is then associated with anxiety, and avoiding it reduces anxiety. So not driving after an accident, not going into a reptile house in the zoo. So the association thus becomes self-reinforcing. This is by operant conditioning, and it becomes increasingly difficult to be exposed to the natural stimulus. For example, not getting into a car at all, not going to the zoo at all. These theories explain why techniques such as exposure response prevention are effective. We've talked about assessment, clinical features, investigations, and differential diagnosis of anxiety and related disorders in chapters 12, 13, 14, and 15. What about management? Hints and tips. Although patients may have genes and life experiences that predispose them to anxiety disorders, often maladaptive patterns of thinking and behavior exacerbate and maintain symptoms. This means that psychoeducation and psychological therapies can be very effective. Communication. When describing psychological therapies to patients, you may wish to remind them that avoidance perpetuates anxiety. To overcome anxiety, it is necessary to feel anxious. Psychological therapies guide patients to do this in a structured and gradual manner. Psychological therapies are recommended as first-line treatment for anxiety disorders, particularly milder forms. Pharmacological treatments are also of benefit, but longer-term treatment is generally required, so the risk for side effects and complications is high. Pharmacological treatment can be offered first-line for moderate to severe anxiety disorders if a patient wishes this, or if psychological treatment has been insufficient. In severe cases, combining the two is required. Here we have a figure that summarizes the most important concepts in treating anxiety disorders based on the NICE guidelines for common mental health disorders: generalized anxiety disorder and panic disorder 2011, PTSD 2005, and OCD in 2005. It is important that you familiarize yourself with this diagram, as anxiety disorders are common in primary care settings and 90% are managed there. So if we have a patient with low anxiety or mood, so what should we do? If harmful or dependent alcohol or other substance use, you treat use first. This often leads to large improvement in anxiety or depressive symptoms. So then you treat alcohol use. Okay. If anxiety symptoms secondary to depression, then treat depression first. If depressive symptoms secondary to anxiety disorder, treat anxiety first. If unclear, ask patient their preference. Okay. Then you should identify diagnosis and severity. Select appropriate treatment in consultation with patient. So you have these diagnoses: the disorder, and here we have the psychological and pharmacological therapies. For generalized anxiety disorder, for mild to moderate, which means minimal functional impairment, you need psychological therapy. For generalized anxiety disorder, you need just self-help psychological therapy, okay, self-help. But for moderate to severe, which means mild marked functional impairment, this is moderate, or persistent subthreshold symptoms, this is also moderate to severe. It includes to treat that you may need psychological and pharmacological therapies, or actually. So in generalized anxiety disorder, you need CBT, applied relaxation, and for pharmacological therapies, you need SSRIs. Second line, you may give alternative SSRI or venlafaxine or pregabalin. Panic disorder with or without agoraphobia, mild to moderate self-help, moderate to severe CBT with SSRI. Second line, you can use tricyclic like imipramine or clomipramine. Social phobia, mild to moderate self-help, moderate to severe CBT plus SSRI. You consider PRN propranolol to treat physical symptoms. And second line, you can use MAO inhibitors. And when you use benzodiazepines, you use them just for short term. OCD, if mild to moderate, you use self-help. You can use individual or group CBT with exposure and response prevention, of course. If moderate to severe, you use CBT, but individualized CBT with exposure and response prevention. And pharmacologically, you can use SSRI, and second line, you can give an alternative SSRI or clomipramine. Clomipramine is a tricyclic with serotonergic effect, a good serotonergic effect. PTSD for mild to moderate, watchful waiting if within 4 weeks of trauma. You can use trauma-focused CBT or EMDR if greater than 4 weeks since trauma. But moderate to severe PTSD, you use trauma-focused CBT or EMDR with some drugs like paroxetine. This is an SSRI, mirtazapine. Second line, you can use amitriptyline and tricyclic, phenelzine. Sleep, if there is any sleep disturbance, you can manage them symptomatically by Z drugs or benzodiazepines, cautiously. Specific phobia. If mild to moderate, you can give the patient some kind of self-help. If moderate to severe, you can use CBT by desensitization, flooding, or modeling. And you can use PRN benzodiazepines if these symptoms rarely occurring in some situations. Okay. Then consider referral to secondary care if risk of for self-harm or suicide, marked self-neglect, non-response to at least 2 treatments, significant comorbidity, substance use, physical health problems. Okay. What about psychological treatment? There is strong evidence for the use of cognitive behavioral therapy in most anxiety disorders. CBT is the first-line treatment for specific phobias, mainly in the form of behavioral therapy, which may involve systemic desensitization, flooding, or modeling. In panic disorder, CBT may help the sufferer to understand that panic attacks can start from a misinterpretation of a normal stimulus, leading to a vicious cycle of spiraling fear and sympathetic activation. When the patient understands this model, the therapist may encourage the patient to break the cycle by challenging the assumption that the original stimulus, like palpitation, is indicative of an impending physical dysfunction, like heart attack. Effective treatments in PTSD include trauma-focused CBT addressing thoughts and behaviors related to memories of the trauma, or eye movement desensitization and reprocessing therapy, EMDR, where the patient is asked to think about the trauma while also attending to another sensory stimulus like lights or peeps. Psychological debriefing immediately after trauma is not advised. Applied relaxation is used in generalized anxiety disorder. This focuses on being able to relax muscularly during situations in which the patient is or may be anxious. Other therapies commonly used in anxiety disorders include supportive, psychodynamic, and family therapies, although there is less evidence for their efficacy. Counseling may be helpful for patients who are experiencing stressful life events, illnesses, or bereavements. What about pharmacological treatment? In general, drugs need to be titrated up to higher doses and take longer to work in anxiety disorders than in depression, up to 12 weeks at the British National Formula maximum dose for a trial of an SSRI in OCD. SSRIs are first-line treatments for most anxiety disorders due to their proven efficacy and tolerable side effect profile. Venlafaxine has a similar side effect profile and also has proven efficacy in generalized anxiety disorder. Restlessness, jitteriness, and an initial increase in anxiety symptoms may occur in the first few days of treatment, and either the SSRIs or the tricyclic antidepressants, which may reduce concordance in already anxious patients. This can be managed by titrating the dose up slowly or by using benzodiazepines in a combination with antidepressants during the first few days of treatment. Benzodiazepines are highly effective in reducing anxiety. However, the rapid development of tolerance and dependence means they are not recommended for the majority of anxiety disorders. They can be prescribed as short-term hypnotic in PTSD, or for infrequent as required use in social phobia, like to allow a speech to be given, or specific phobias like to allow blood to be taken. They are not recommended for generalized anxiety disorder, panic disorder, or OCD unless used for short term in a crisis. Okay. Pregabalin is licensed for treatment of generalized anxiety disorder, often used after an SSRI trial, epilepsy, and neuropathic pain. Tricyclic antidepressants are generally considered only after other treatments have been tried, owing to their increased frequency of adverse effects like dry mouth, sedation, postural hypotension, and tachycardia. Clomipramine, the most serotonergic of the tricyclic antidepressants, has proven efficacy in OCD. Monoamine oxidase inhibitors, despite being effective in some conditions, are not considered first-line treatment for anxiety owing to the possibility of severe side effects and interactions with other drugs, food components, and so on. A beta blocker such as propranolol can also be used as required to reduce autonomic arousal or anxiety-inducing stimuli, but it is more effective to treat the anxiety directly if possible. Hints and tips. Inhibition of serotonin uptake seems to be the essential component of effective drug therapy for obsessive-compulsive disorder, as evidenced by the efficacy of the selective serotonin reuptake inhibitors and clomipramine. Clomipramine, which predominantly inhibits serotonin reuptake, is more effective than other tricyclic antidepressants, which prominently inhibit noradrenaline reuptake inhibition like disipramine or nortriptyline. What about the course and prognosis of anxiety disorders? The prognosis of the anxiety disorders vary greatly between individuals. Generalized anxiety is likely to be chronic but fluctuating, often worsening during times of stress. Panic disorder, depending on treatment, up to one half of patients with panic disorder may be symptom-free after 3 years, but 1/3 of the remainder have chronic symptoms that are sufficiently distressing to significantly reduce quality of life. Panic attacks are central to the development of agoraphobia, which usually develops within 1 year after the onset of recurrent panic attacks. Social phobia usually has a chronic course, although adults may have long periods of remission. Life stressors like new job may exacerbate symptoms. Specific phobia have an uncertain long-term prognosis, but it is thought that simple phobias that persist from childhood are less likely to remit than those that begin in response to distress in adulthood. PTSD, approximately half of patients will recover fully within 3 months. However, 1/3 of patients are left with moderate to severe symptoms in the long term. The severity, duration, and proximity of a patient's exposure to the original trauma are the most important prognostic factors. OCD. The majority have a chronic fluctuating course with worsening of symptoms during times of stress. About 15% of patients show a progressive deterioration in functioning. Okay, what about dissociative and somatoform disorders? The dissociative disorders were described in Chapter 14. The common somatoform disorder is somatization disorder. This is in ICD-10, of course. And hypochondriacal disorder and body dysmorphic disorder. Factitious disorder and malingering were discussed in Chapter 15. Let's talk about epidemiology. Here we have this table that represents the epidemiological data for somatoform disorders. Somatization disorder, the lifetime prevalence is 0.2 to 2%. The age of onset usually is before 25 years of age and often in adolescence. And it is far more common in women. It's about 10 to 1 related to men. Hypochondriacal disorders, the lifetime prevalence is 1 to 5. The age of onset is usually adulthood, and the sex ratio is equal. Body dysmorphic disorder, the lifetime prevalence is 2%. It starts in adolescence, and a slight female excess here. Functional dissociative disorders, there's no information here about life prevalence, but the age of onset varies between specific disorders according to the case. We have more than one disorder. Functional or dissociative disorders are even more common, around a third of patients seen in hospital medical outpatient clinics. Functional seizures are found in around 1 in 7 people attending a first fit clinic. Functional paresis is as common as multiple sclerosis, affecting around 4 in 100,000 people per year. And up to half of presentations with status epilepticus are in fact prolonged functional seizures. About the etiology of dissociative and somatoform disorders is poorly understood. Childhood sexual abuse increases the risk for somatoform and dissociative disorders, although the majority of patients with the disorder have not been abused. Growing up in environments where physical distress is more readily acknowledged than psychological distress may have a role. Symptoms often, but not always, have onset or worsen after a stressor, and this may be because emotional states influence the way pain and other bodily sensations are perceived. Symptoms also often follow an actual minor physical insults. For example, functional leg weakness following a sprained ankle, or irritable bowel syndrome following a viral infection. Similarly, functional seizures occur most often in people who also experience epileptic seizures. There is no convergent pathophysiological explanation, but current theories include abnormal intense self-directed attention interferes with normal autonomic cognitive processing, causing errors, much like thinking too long about how to spell a word. Much sense of agency or disrupted sensory prediction prevents patients from differentiating self-generated versus involuntary movements, or normal from abnormal sensory input. We've talked about assessment, clinical features, investigations, and differential diagnosis in chapters 14 and 15. About the course and the prognosis. Somatoform disorders tend to have a chronic episodic course, with waxing and waning symptoms, often exacerbated by stress. Good prognostic features in hypochondriacal disorders include acute onset, brief duration, mild hypochondriacal symptoms, the presence of physical comorbidity, and the absence of a comorbid psychiatric disorder. Functional dissociative disorders vary widely in outcome. Some patients experience one acute episode, then make a full recovery. Others become very disabled. About management. NICE 2005 recommends CBT, including exposure with response prevention, for body dysmorphic disorder with any degree of functional impairment. SSRIs are recommended in addition for those with moderate to severe body dysmorphic disorder. Little research is available regarding the treatment of somatization and hypochondriacal disorders. Pharmacotherapy will only alleviate symptoms when the patient has a comorbid drug response condition such as an anxiety disorder or depression. Both individual and group psychotherapy, mainly CBT, may be useful in reducing symptoms by helping patients to cope with their symptoms and develop alternative strategies for managing their emotions. Okay, here we have a box that summarizes the role of general practitioner in managing patients with somatoform disorders. Okay, we will talk about that in a minute. A supportive relationship with an empathic doctor able to work with the patient to guide understanding of their condition is likely to be the most important intervention. In functional dissociative disorders, a clear and empathically delivered explanation that emphasizes reversibility can often be helpful. Treat comorbid psychiatric disorders, consider CBT, and consider physiotherapy for those who are deconditioned. Here we are talking about the role of the general practitioner in managing patients with somatoform disorders. First, arrange to see patients at regular fixed intervals, rather than reacting to the patient's frequent requests to be seen. Increase support during times of stress for the patient. Take symptoms seriously, but also encourage patients to talk about emotional problems rather than just focusing on physical complaints. Limit the use of unnecessary medication, especially those that may be abused, like benzodiazepines or opiates. Treat coexisting mental disorders like anxiety or depression. Limit investigations to those absolutely necessary based on objective signs. Have a high threshold for referral to specialists. Communicate the diagnosis clearly and empathically. If possible, arrange that patients are only seen by 1 or 2 doctors in the practice to help with containment and to limit iatrogenic harm. Help patients to think in terms of coping with their problem rather than curing it. Involve other family members and carers in the management plan. Consider referral to a psychiatrist or psychologist. Okay. Communication. A diagnosis of functional symptoms can be hard to explain. Phrases such as "you are experiencing a functional, not a structural problem," or "a software, not a hardware problem" may help to reassure patients that you believe they are experiencing symptoms, but these are not driven by a disorder which requires specific treatment. Here we have some explanation and advice in dissociative functional disorders. State what is wrong, like you have functional seizures, you have irritable bowel syndrome. Okay, state what's not wrong. You do not have epilepsy, or celiac disease, or bowel cancer, etc. Describe the mechanism. Your body is not damaged, but it is not working properly. Okay, try metaphor, like it is a software, not a hardware problem. Explain how the diagnosis was made. Demonstrate tremor, entrainment, Hoover sign, etc. Share normal investigation results. Point out other symptoms such as derealization and depersonalization. State you believe them. I do not think you are making these symptoms up. Emphasize the problem is common. Many people have similar symptoms. Emphasize the problem gets better. There is no damage, so there is potential to make a full recovery. Emphasize self-help. It's not your fault, but there are things you can do to make it better. Okay, we reached the chapter summary. Anxiety disorders are common, often chronic conditions, arising more frequently in women than men. Self-help is the first-line therapy for the majority of mild anxiety disorders. Psychological therapies are first-line for moderate to severe anxiety disorders. Medication, usually selective serotonin reuptake inhibitors, can also be offered for moderate to severe anxiety disorders. Principles of treatment in somatoform and dissociative disorders are to take a holistic approach, give a clear explanation of diagnosis, and minimize iatrogenic harm. So that's it. هذا والله تعالى أعلم، وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.